Bueno, consideraciones anatómicas y fisiológicas.
Anatomical and physiological considerations of the vein of Marshall. It is not a new discovery. The vein of Marshall has been known since 1908 when Marshall described it. It is a branch of the coronary sinus, the only atrial vein that is consistently present in almost everybody. It is a remnant of the left superior vena cava, and its trajectory is from the coronary sinus anterior to the left pulmonary veins in the epicardial aspect of the left atrial ridge. It's a vein in itself. It is not a remnant of the left superior vena cava. It is an atrial vein with atrial venous return. It has its connections with the atrium and connections with the atrial myocardium. That has to be borne in mind. It's a muscle fiber that Dr. Dave Kimper, who worked with me, showed that it had connections in what is called the ligament of Marshall, which is the atretic vein. It has connections with the myocardium, with the nearby myocardium, and has a very rich innervation, both sympathetic, as you can see, when you use tyrosine hydroxylase stain, and parasympathetic innervation around the vein of Marshall, as you can see with acetylcholinesterase. Its involvement in arrhythmogenesis dates back to 1972 when Dr. Shellac in Oklahoma stimulated cardiac nerves outside the heart in the mediastinum. And when stimulating the left side in the cardiac nerves, he found that tachycardia was produced. I'm going to cut the story short, but for 10 years now, I have had this idea of being able to use this knowledge of basic science and translate it to a clinical application. And we started 10 years ago with the idea of cannulating the vein of Marshall and develop a protocol of a procedure that could be applied in humans. We first worked in dogs to determine whether it could be done, and after a lot of paperwork and a lot of administrative struggles, we managed to do the first case in humans. I'm going to skip all of my battles of these past 10 years, but I'd like to summarize the procedure in a video. First, we cannulate the coronary sinus with a sheath, the conventional sheath. For insertion of the electrode into the left ventricle, it's placed inside the coronary sinus, and orienting the tip, we inject contrast to opacify the vein of Marshall. We need to orient the nema posteriorly. Once we have localized the vein of Marshall, we then advance an angioplasty guide wire and a balloon. The guide wire is advanced as much as possible, and the balloon is advanced inside the vein of Marshall as much as we can. Once we place the balloon as distal as possible, and that is where we inject the first alcohol. We inject contrast to see where the alcohol goes. We see some staining of the myocardium here, and then we deflate the balloon. We pull it back a little. It's a little bit lower. We again inject contrast to know where it is going. The vein is there. We see myocardial staining, and this is important because it proves the concept that I was telling you about before, which is that the vein of Marshall is a real vein with venous return from the left atrium. So, in 4 steps, we complete, and we inject on 4 locations at the different points along the vein of Marshall. So again, we identify the vein of Marshall with posterior rotation of the lemma. Here we see it here. We advance the angioplasty balloon and wire. As you can see here, we advance the balloon. We make the first injection. We see that there is going to be myocardial staining to demonstrate that there are capillary connections with the myocardium. It is not just a remnant of the superior vena cava. Second injection, a little bit lower, and you can still see the contrast. The third injection will be even lower. Third injection. the capillaries have been obliterated and we see a posterior branch. And the last injection is usually done in the ostium of the vein of Marshall, very close to the coronary sinus. So as you see, we always get myocardial staining, and that's where the alcohol will go to do its therapeutic effect. After demonstrating that this was feasible, we demonstrated that some pulmonary veins could be disconnected using alcohol injection in the vein of Marshall. This is work published in 2012 in a vein of Marshall with different branches. Here we have the lasso on the left upper pulmonary vein. Upon injecting alcohol, the disconnection is achieved, and we discovered that the lower left pulmonary vein was also disconnected. This is not something that happens every way, but in patients who have been ablated previously with epicardial connections, we can eliminate them very easily with the alcohol. The idea that there are triggers of AFib in the vein of Marshall was explored systematically in 54 patients who had failed ablation for AFib, and trying to stimulate the triggers with isoproterenol combined sometimes with adenosine. This is a very infrequent finding. In fact, only in 2 out of 54 patients were we able to demonstrate that there was demonstrable of triggers of AFib coming from the vein of Marshall. Specifically, this is one of those cases where we did a mapping to map the vein of Marshall after giving alcohol. The bradycardia came to an end, and after more alcohol, we isolated that vein and the pulmonary vein as well. So as I say, this is an infrequent finding, but what is clear is that beyond conjecture of whether there are triggers of the vein of Marshall, if there is any innervation, or what are the mechanistic indications. What is clear is that injecting alcohol in the vein of Marshall is a useful therapeutic tool and can give rise to a myocardial ablation that can be used in different clinical situations. And this is what we get with the injection in the vein of Marshall. This is a patient with an MRI using gadolinium before and after alcohol, and we can see that the ridge and the myocardial segment between the mitral ring and the pulmonary veins is left with the delayed enhancement. Yeah, very similar. Here we have the right ventricular outflow tract, and we see the basal ridge, and we see that it doesn't have a dense echogenicity. But after alcohol, we see that the density is augmented. And if we have an endocardial voltage map, there is a scar, as was expected, from the mitral ring towards the ridge and the anterior aspect of the left pulmonary veins. And I would like to caution you regarding the estimation of the ablation created by alcohol based on endocardial voltages. Alcohol is administered from the point of view of the vein. It is epicardial, from epicardium to endocardium. When we do an epicardial map, it may be that we are not exactly mapping the lesion created by the alcohol. The endocardium will probably survive because it has, well, remember that this is retrograde flow. When I inject alcohol in a vein, the arterial flow is against me, and it's going to want to wash out the alcohol as I inject it. So many times this scar, which we measure endocardically, in the first few minutes we cannot see it, and then we start to see more. After 10 minutes of giving the alcohol, it's when we see it larger, and if you map the patient 3 months later, it is a little bit smaller than the original one. We need to emphasize that this is a purely epicardial ablation. According to your experience, it takes 30, 40 minutes. This procedure takes 30 to 40 minutes. In the initial experience, we would use 8 minutes of fluoroscopy, and the alcohol area was measured at around 9 to 10 square centimeters. Regarding the scar surface measured by endocardial mapping. So the more you do it, the more procedures you do, you can do it faster, it's more feasible, and there is less disruption caused by the procedure in general. Now, the next information that we assessed is in line with what we've discussed today. How does alcohol in the vein of Marshall help eliminate conduction through the mitral isthmus? And what we did here was to take two groups of patients, 50 patients who had flutter or recurrent fibrillation after a prior ablation, in whom, in half of them, ablation of the mitral isthmus had been done. And then the second group, de novo patients with the first ablation. And what we did was to look at the perimetral conduction using differential stimulation as we did today. First stimulating the appendage and then the coronary sinus to see if we could achieve perimeter blockade with the injection of alcohol. Alcohol injection in the vein of Marshall, rarely will it yield a perimeter blockade in itself, because the coronary sinus is an atrial structure. There is atrial tissue between the coronary sinus and the mitral valve, and therefore that tissue will not be affected by alcohol. The balloon has a length, the minimal length of 6 millimeters. Today we're using a 15 millimeter balloon. So if we're going to be inside the vein of Marshall, there's part of the vein of Marshall that will not be exposed to the alcohol. And out of need and by definition, the lesion that we create using alcohol in the vein of Marshall will never reach the mitral annulus. It will be 2 or 3 centimeters in the mitral isthmus of the valve, from there to the vein of Marshall. That requires little. What we found is that in patients who had had prior ablation, we needed a mean of 2 minutes of RF to achieve bidirectional blockade, and that RF had to be applied in the more annular part of the mitral isthmus, in the part not affected by the alcohol. What's interesting is that in the group that had de novo ablation, who had not had ablation, prior ablation of the mitral isthmus, the time required to achieve bidirectional blockade was the same. The idea here is to show that if you want to create a blockade in the mitral isthmus, the technique for alcohol injection is really useful. And there are some cases very similar to the one we showed today, where really we see the role that can be played by epicardial connections to the ridge in order to sustain a re-entry perimetral blockade. A patient with flutter after having been ablated previously, when we did the initial map, we found that there is a counterclockwise rotation around the mitral annulus, but there was a scar area where there was no measurable voltage. We couldn't record activation times there because there was no signal, and really we didn't have all the re-entry circuit. We were lacking 25%, and what we did based on our prior experience was to cannulate the vein of Marshall, inject and place an angioplasty guide wire with balloon, and configure the guide wire as a unipolar electrode in order to record activation times along the vein of Marshall. And this is the NAVEX point. If we add the times that could be recorded through the vein of Marshall, we can see that the latest portion in the circuit was in the epicardial aspect. Today, we were able to describe this concept very clearly when Fermin, where we had the coronary sinus catheter equidistant, there was a scar. We had the lasso here on the appendage and the ablation catheter here. And by stimulating here, we found that the earliest after stimulating here was the vein of Marshall up here, then the ablation catheter that was down here was later than the vein of Marshall up here, showing almost irrefutably that the connection through the isthmus was through the myocardial around the vein of Marshall. It's hard for me to say that it is the vein of Marshall that does this connection. It's the myocardium by the vein of Marshall. The vein of Marshall is a vein. It's not myocardium. It cannot have an ability to connect, at least here. We were able to complete the map with all the re-entry circuit and when the alcohol was injected, the flutter was inhibited. A very interesting thing from the mechanistic point of view for my friends, the neurocardiologists, Dr. Kumar and all of here. We conducted a mechanistic study in humans to the extent that it can be done, and we try to see the content of parasympathetic innervation of the vein of Marshall, and we developed two protocols. The first one consisted of doing high-frequency stimulation synchronized with a P wave through the vein of Marshall. So we placed a catheter. At that time, we had Kavima. It doesn't exist anymore. This is a quadripolar catheter. Placed it in the vein of Marshall and synchronized with the P wave. We placed high-frequency stimulation, a very short duration, so we never captured the atrium. It was refractory. We synchronized with a P wave. We stimulate. We know that it is refractory. The atrium is refractory. It will not be captured. There is no stimulation of the atrium. And after doing it during 1 minute or sometimes immediately, in half of the patients, we would induce fibrillation. But look how the fibrillation is induced. Here we have the high-frequency stimulation, and then atriosinus, and then the fibrillation starts. And where does it start? The first signal that we have with fibrillation begins the vein of Marshall. We give alcohol, we'll repeat the same procedure, and we find that by doing the same thing with high-frequency stimulation in the vein of Marshall, synchronized with the P wave, we do not only capture the atrium, but we do not induce fibrillation either. This protocol was quite complex. We had to use a stimulator, which is not the usual one. We abandoned it, and what we did was develop a simpler protocol, which is merely to place the catheter in the vein of Marshall and stimulate for a long time using high-frequency stimulation for several seconds. And if we capture the atrium, we're going to induce fibrillation always. There's no value to it. But the interesting thing was that in 80% of the patients, when the high-frequency stimulation protocol was done, we induced fibrillation, yes, but also asystole with complete AV block during 5 or 8 seconds. This is fascinating because the vein of Marshall is here, the lateral wall of the right atrium. The AV node is in the septum. And in one way or another, we are stimulating neurons which through interneurons connect with the plexus that controls the AV node, creating a parasympathetic response. What's interesting is that after doing this, we apply alcohol, we repeat the procedure, and this time we do not capture because we have ablated the myocardium there, but we don't have a parasympathetic response either. So this is a subject for debate, but if it has any clinical value, I don't know. But at least mechanistically, I can say that indeed the parasympathetic innervation surrounding the vein of Marshall can be eliminated with alcohol. We're studying this more rigorously in a randomized trial in patients with persistent AFib who are having their first fibrillation ablation, and they are randomized to pulmonary vein ablations, plus what the operator needs considered to be needed alone or combined with alcohol in the vein of Marshall. This is a study. It's going to include 336 patients. We have recruited 273. These are the 11 centers, and I hope to be able to complete this year or early next year. This has been really a big headache over the past 5 years, but we will come to an end with it. We will complete it. Okay, we'll take a look at a case. This is what Dr. Science asked me to do, a 65-year-old patient who came for ablation for persistent fibrillation with a history of paroxysmal fibrillation for 2 years, but it has become persistent for 7 months. First, he got cardioversion and was treated with dronedarone, obviously with recurrence. And he was brought in for fibrillation ablation, and he was given a lesion, a box type lesion with a line on the summit, an anterior line to the right pulmonary veins and above on the ridge, creating an isolation posterior wall, combined with a line in the mitral isthmus because the patient developed perimetral flutter, and also in the tricuspid. Everything went well, and 2 months later, he presented with atypical flutter. This is treatment with propafenone with a slow flutter. We brought him in for ablation. We placed a duodecapolar catheter so that the distal poles are in the coronary sinus and the proximal ones are in the tricuspid annulus. And here we are stimulating in the cavo-tricuspid isthmus. The interval after the stimulation is a long interval. It is shorter in the ostium. And in the distal coronary sinus, it is shorter. In the roof of the atrium, it is longer. But at no time did we have a post-spacing interval that was at the same. We don't know if this is because of the medication or whatever, but we never had a good entrainment. And we see an activation map where we see that there is a perimetral rotation that appears to be clockwise. But curiously enough, we don't have the entire cycle, the cycle length of reentry. If it was 450 milliseconds of the cycle length, we had to cover at least 100 milliseconds. The earliest area was right here, but it was very delayed as compared with the later area. We would have to see this there. This is the earliest point.
Como pueden ver, nos falta.
As you can see, we still have to cover all this part of the length of the cycle of reentry. We did ablation, endocardic ablation, following the conventional approach. After 540 seconds, and burning this with no piety, nothing changed. And to enter the Marshall vein and inject contrast, and that was the end of the flutter, simply by doing this with contrast. I don't know whether the contrast has any electrophysiological effects or just a mechanical effect of injecting contrast, just put an end to flutter. After injecting contrast, we went into the Marshall's vein with the guide wire and the balloon. Here is the balloon. You can see the vein of Marshall's, very small. As you can see, it's a small, irregular vein. It has been ablated extensively from the endocardium. So that makes the vein of Marshall not very big or very pretty. Then, by pacing, we see that the activation of the coronary sinus goes from proximal to distal, stimulating. This is the final map. This was done during the first ablation, and now we have a more extensive ablation to complement the prior one, stimulating the distal coronary sinus. The pacing of the appendage is very late, and here we finish. This is very similar to what we saw today. This is a therapeutic tool that can be useful in many cases. In cases of perimetral flutter, particularly refractory to endocardic ablation, it is very useful. That has been my conventional practice beyond the clinical trial. Patients with post-ablation flutter, this is the procedure I offer them. If the clinical trial shows that de novo to add ablation through the vein of Marshall changes the results, it would even be better, but it is yet to be seen. If you have any questions, please let me know.
85% in general.
85% en general.
So, la vena está. Lo que pasa es.
Is there. But sometimes the vein is smaller or larger, easier to cannulate, more difficult to cannulate. It's a procedure that, of course, becomes more successful the more experience the operator has. In the clinical trial we have, in order to have the same number of patients treated with alcohol as of controls, we put 15% more patients in the Marshall vein group to make up for 15% of technical failures. The truth is that it can be more. If I don't go into the vein of Marshall's, what I do is to go into other veins. It has been published in JACC and EP, a complete atlas of all the veins. For instance, the septal vein, immediately after the ostium, there is a septal vein which runs through the lower aspect of the septum. There is a lower vein that covers the posterior wall of the left atrium, then the Marshall vein. then the appendage vein, and then there is an anterior vein which comes from the mitral annulus medial to the appendage and connects to the right superior pulmonary vein. And sometimes I have done perimetral blockade with alcohol with an anterior mitral line.